So thank you again. That's a privilege to be here. It's we are back to the CAF lab number 4. We are here with an interest case from coronary intervention. To my left here, there's Jose. He's a fellow. Rodolfo will be the first operator, and there's Diego from Bolivia, Cochabamba. It's correct. And we have all the staffs from the nurse. We have Daniel from Microport, and we'll be reviewing this case. That's a really interesting case. If you, Jose, could present us the case now.
Yes, may I have the presentation, please? Okay, so I have by my right Louis Ohi. He forgot to introduce himself, but he's one of the staffs here too at Dutchy. Okay, so we have a 66-year-old male. He was asymptomatic before. He underwent a routine checkup for coronary heart disease, and he had an exercise stress test that was positive for ischemia. So his doctor
Refer him
thought,
to.
yeah, he referred him to CT that showed multivessel coronary disease. He had no previous comorbidities before undergoing these routine checkups. Do you do this on a daily basis if the patient has nothing, no symptoms, no comorbidities?
No. There will be no whatsoever. There will be no routine for how can I say a routine checkup with the angel CT. But how can I say in Brazil it's pretty common that the kind of and it's how can I say we are going to show all the findings from the CT and the angel that he got it after he was referred to this routine checkup.
Okay, so just for you to know, all the exams, all
The previous
the
exams.
previous exams he done on a different hospital. He was not here at Dutchy. So the patient is currently under use of DAPT and atorvastatin. He has pretty much innocent laboratory tests, and he has preserved contractility on transthoracic echo. So the patient underwent coronary angiography last month. He performed it at another hospital that didn't have any surgery team backup, and then he was transferred to Dante Pazanetti for a surgical evaluation. At the heart team discussion, the surgical team thought that the distal vessels were not suitable for surgery, so it would be an incomplete revascularization. And the patient was also willing to undergo PCI and not surgery if possible. His EKG is pretty much normal. He has only inferior wall repolarization abnormalities. And this is the coronary angiography that, once again, he made at a different hospital. You can see, you can appreciate the right coronary artery that has a distal lesion and a lot of calcium too. Here again, you can pretty much see that it's a distal lesion that involves both the posterior ventricular and descending posterior. This is where it gets tricky. So we saw this angiography at the heart team, and no one was really sure where the lesion really was. Okay, so there's a distal lesion on the left main that involves both LAD and circ. Louis, what do you think?
Yeah, it's from this projection. It will be how can I say tricky because you quite can you don't know what you're looking at because you can see some calcium and you don't know if it's the ostrum from the circ or is the distal left main, and you don't know by the high degree of calcium if it's a calcified lesion or perhaps the attenuation from the dye, concert dye that you're not able to see through the entire left main through the circ. So it's quite difficult to how can I say establish
Yeah.
how much the degree of the how can I say the lesion are. Let's say
Okay,
okay.
so we have a few other projections here. You can see that it's a heavily calcified left main, especially on the distal portion of it. And there's also a high diagonal branch that comes right off the LAD origin. Once again, this is pretty much you can't see anything in here, right, Louis?
Yes, correct. You can define what's the lesion whatsoever.
And on the spider view, you can appreciate that there's some haziness on the proximal left circ, also on the distal left main, involving also the LAD ocean. But once again, this is not well established.
Yeah.
This is the left ventricle. He had preserved ejection fraction. We calculated all the scores as we always do on our heart team. And even though you can see that the patient has intermediate to high syntax score, the heart team decided that the best approach here would be PCI, and also with the patient willing to undergo PCI, right, Louis?
Okay. Just to summarize, this is a symptomatic patient who did this checkup and he was referred to Cambridge from another institution 2 hours, and we did a heart team. Yeah? That's correct. And so they thought it would be better by the decision from the heart team, and also with the regardless towards the patient's point of view. So we are now going to do this on live case. So what have we done so far here, Rodolfo and Jose?
So
If
we
you can
started
put
with coronary angiography. Can you
put the angel here on big screen here? Okay, perfect. So this is the angel that we just did right now here, correct, Jose?
Yes, so we just did it. So on the coronary angiography with better projections and better angulation, we can appreciate that there's a distal left main lesion that involves both LAT and left circ. And the haziness also on the left circumflex, it can be better appreciated here. There's a haziness on the proximal left circ.
And a lot of calcium.
A
Yes,
lot
a
of calcium.
Yes.
Also, we can see here that the LAD has a proximal lesion and two diagonal branches that comes right off its origin. So we have the LAD osseum followed by two diagonal branches, one branch that is really important, it's huge, and the other one that is not that huge.
Yeah. And perhaps here you can see perhaps a little bit on the ostrom from the circ that will be a little bit tight lesion here from this projection. If you yes, perfect. Well, now it's left projection. I don't know cranial. I don't.
Yeah, you can better appreciate some of the left from the LCx, the lesion over there.
Yeah.
That we can see it as a haziness on the caudal view,
It's
and
a eccentric lesion.
yeah, it's an eccentric lesion.
Yeah. With a lot of calcium.
This is on the spider view.
Yes.
It's better angulated, so we can see pretty much the LAD osseum, the LCx osseum, and the calcification, the calcified lesion that involves both the osseums.
Yes. Okay. So, Rodolfo, would you think about treating the mid portion from the circ? It's a moderate lesion, would you say,
Yeah.
Rugi?
I don't treat now.
Okay.
I focus in proximal, in osteo and proximal circle.
Yes.
Yeah, we can also evaluate by physiology, right?
Yeah.
After treating the LCX
main.
and LAD with the left main, we can evaluate everything again with MIFR or
Yeah.
Yes.
or even IFR.
Yes, actually. So we did an IVUS, correct? So we did an
Yeah,
IVUS.
so we opted to perform IVUS to better determine what the degree of calcification was, and also take a look at the both of the LAD and LCX osteums.
So let's see. Okay, perfect. So
Okay.
let's review the circ here. If you can put the IVUS on the big screen now. The IVUS here. Thank you. Oops, blue screen. It's the angel now and the IVUS. It's the MIFAR. It's the next one. Oh, perfect. So here we are seeing the distal portion from the left circ here. and we're just going to play. And there's some, I don't know, mid stenosis here. There's no so much degree of calcification. Will you agree, Jose? It will be almost normal, pretty normal here.
Yeah, there's
So yeah,
180 degrees of calcification.
yes, 100 degrees. So when you the mid portion is get a little bit straight here. I calculated a area here. It's about 3.9 here, and almost like 270 degrees of calcium here. When you go most to the proximal and after some marginal branch here, that will be, how can I say, a little bit more timed up. It will be a little bit more severe lesion, calcified, almost 180 here, and it'll be here just from this point here when you're going up to the ostium and then to the distal left main. So, and the distal left main is like 5.2. When you go to the LAD, I was from the LAD, well, from the mid portion, it was like almost normal vessel here. And when you go up to the, it will be a septal branch here, and it will be like most tiny stenosis here. I appreciate almost 306 degrees of calcium. They're pretty tight and calcified lesion here. So that will be almost the mid portion from the LAD. And we are going to see up to the left main here. Okay, perfect. So 3.5, 3.6 left main, and after the distal portion of the left main, it will be almost normal vessel. What will be the strategy now?
Rodolfo, looking at the image, you can see that almost 360 degrees of calcium right on the septal branch. Would you do hot ablation or shockwave first, or try balloon
First,
angioplasty, POBA?
first we try 1-to-1 non-compliant balloon.
Okay.
3O balloon in this case, 1-to-1, high pressure. If we
The balloon responds to the
respond, okay. If it didn't response, we use a hot ablate or shockwave.
Okay, so Rodolfo is the one that has most experience here. He's been doing this for what, 30 years
yes
or more? So we're gonna follow with his opinion on the case. We're gonna start with POBA on the LAD as 1-to-1 ratio. So we chose.
And this is the SKY algorithm for calcified lesions.
Yes.
Just summarize, this is our routine here, Rodolfo, because we always try to do a POBA before we escalate to the upgrade to the rotabator or shockwave, whatever, because that will be a routine from that. Is that correct?
Yeah.
Okay.
So we chose a 3.0 by 20 balloon that we're gonna take down to the LAD.
Circumflex. Left
But this is going to the circumflex.
Yes,
Okay.
sir. Okay. Let's hope that we don't have to use the rotablator here. Okay.
We with a 7 French catheter.
Yes, from the femoral
with a
approach
femoral
here.
approach. The radial artery is not. It's a small one.
Yes, not suitable for radio approach, the patient here. What will be the guide wires that we use here?
We have 3 pilot 50s. We have a pilot 50 on the left circumflex, a pilot 50 on the first diagonal branch, and one on the LAD too.
Yes.
Test.
Okay, just leave me the test here. It's a little bit out. So you
Okay. What?
usually use a polymeric guide wire because the strategy here is to use two stenting, so you don't want to
Pinch.
be the guide wire stuck to
Wait,
the struts behind yet. Is that correct?
20?
Yes, we always the
25?
stent's gonna be stuck on the back of the stent.
Inflate?
We prefer to use the polymeric guide wire.
What will be the feeling about the balloon here, Rodolfo? Will it be
It's full expanded.
full expandable. So yeah, I think the
I'm
lesion correspond to the balloon POBA. Perhaps.
Just to let you guys know, we went up to
Test.
25 atmospheres
Test.
here.
Okay, let's do some tests here. Oh,
Okay.
here, okay. Oops. Oop.
What do you think? Do you like it?
Yeah. You use a 20 stand,
Yes, 20 stain.
Yeah.
Okay, okay.
3520. This thing, this is,
We're choosing the stent now. We're picking up a 3.5 by 20, perhaps a 23 here.
tô tentando.
Uh,
Aí.
3.5.
Just to let you guys know,
25.
we are performing a decay crush technique, okay?
Desinfla.
3.5 by 23 doesn't know. Okay.
So we pre-dilated the left circ with a 3.0 balloon, and you can see that it still has some difficulty to enter the left circ, probably because of the catheter support and also the
The
calcification.
angulation and the calcification.
Yes.
Ok.
3.23, Rodolfo, pode ser?
3,5, 20.
Tá bom. Ok. So,
Possível?
3.5 by 23 or by 20. 3.5
Okay.
by 3.5 by 3,5 por 20.
35, 3,
Por
3,
20, 23. Não, é stent, gente. Stent.
Peraí. Vai.
So we're choosing now the stent here. So Rodolfo, would you think is would be? Do you think is you have to do pre-dilatation on the LAD also? Would or comfortable only doing the how can I say the balloon tests in the
Balão
circ
não,
here?
The stent in left circle and the
Balloon
same
on the
balloon,
LAD.
LAD.
Yes, because you are doing a decay crush technique, so you are
Yeah.
going to use the same balloon on the LAD to do the crush. Is that
The
correct?
diameter is similar.
Okay. We're choose by IVUS somehow here also. Is that correct? Okay. So we are now moving the same balloon that we did on the circ. We're now using on the
19, 20.
Vai ter que ser
LAD.
23.
19?
Uhum.
Então dá 23.
Okay. Oops.
3,23.
Non-used balloon, so we have to make some adjustments here. Okay.
Ok.
Okay.
Foda.
So we're doing the pre-dilatation on the left main towards to the LAD here.
20?
About
Pode ir.
20 atmospheres here. Okay. So what would be the projection to do a correct decay crush here, Rodolfo?
In this case, spider.
Spider?
Position spider view.
Yeah, it has to be a projection that you can appreciate the ostium, right?
Yes. So you have because
So-
you have to be the minimum protrusion from the stent towards to the left main. Is that correct? Okay.
Stent?
So we're now choosing the stent here.
3,23.
Tem
Yes.
19, 3, 19. Spiral.
323.
Tem 19.
Vai bem aí,
Vai.
23.
So what will be the stent here?
Today we're going to be using the Firehawk Liberty that is from Microport.
It's the new device from Microport. Is that correct, Jose?
Yeah, it's their new stand. It's in their new platform. And this is the first time we're using it.
Yeah.
So,
institution, so-
yeah, this is the first time we'll have experience with it.
But we are using a lot of the previous here on the routine. That's how can I say? It's a good device here. We don't have any.
Yeah, we are used to using the Firehawk, but this is their new one.
It's the it's on routine use here. So now with the stand up to the circ, Should we move to the spider projector here, Rodolfo? Yep.
Not yet.
Not yet. Okay, so we are now trying to make the position from the
This
stand
is a
here.
difficult angulation for a stand, right?
Yeah,
So he performed well, right?
yeah. That's why you like
Now
the
you can move to the spider
yes,
view.
because you can see how much from the catheter responds towards the calcification and the angulation. Is that correct, Rodolfo? So you can when you are doing from the spider view, you can somehow be you cannot correct the position from the catheter here. So
Bomba,
okay,
suflador,
another insufflator here for the
LED.
LED here. So okay, okay. So there is the balloon on
Okay.
the left
LED.
main LED. Okay,
Just like-
here. Jose will be doing the test and the angiograph here, and I'll be
Let me
delivering.
see the
Okay,
photo.
yeah.
Qual photo?
Oh, we have to do it.
Okay, just okay. We're now preparing the balloon on the left main, just to make sure everything will be done correct. Okay. So that's the most important part is when you trying to get the position from the perfect position from the stent on the minimal protrusion towards to the left main. That's how can I say? You have to be a lot of you have to do a lot of case here, né, Rodolfo? So you won't miss and you don't produce too much struts. Okay. So okay. Have the mark almost
Okay.
like 1 millimeter into the left main. Is that correct, Rodolfo?
Okay, the stent is a little bit distal to the
The left.
left.
Okay. This is
Plate.
the stent. Okay.
Devagar. Devagarinho. Dois. Dá um testinho, Zé.
Make
Okay.
sure that the stent didn't move here.
Yes.
Okay. So it's not up to.
Let's move a little bit.
Yep. You have some tension because okay.
Teste. Vai, sobe.
Okay.
Pode ir. Libera.
Okay. So up to
6.
10.
Okay. It's enough. Inflate. I will pull back a little bit.
Yes.
2 millimeters.
Okay. Okay.
12. 14.
We're going up to the
Deflate.
14.
Okay.
Okay. So we're doing a decay modified here. Okay. So I'm using the same balloon from the stents, so we can make sure. Okay, perfect, perfect. Make sure the ostium is full coverage from the ostium. Okay.
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 It's a very good position.
Yes, very good position here. But we still have the balloon on the left main, the LED here.
Yeah. Well, inflate.
Okay. Can you, I think
First
you have
kiss.
to. Yes, first kissing here. Me and Jose were doing simultaneous kissing here. A little bit to 1,
What?
2,
8.
3, up to
8,
4, 8
Deflate.
atmosphere. 1, 2, 3. Okay.
Agora The cranial view, please.
You're going to the cranial view
Yeah.
just to make sure. Perfect. Okay.
Just to check the length of the
Okay.
stent and LID.
Yeah. So what Rodolfo is doing here?
Yeah, he's
position-
pulling back the guide
Yeah,
wire to check on the length of the stent from the left main to the LAD. This is something we do here on a daily basis to
Okay.
get a better estimation of the stent size.
Yes, the length that we're using now.
Distal is okay.
Okay.
Let me see the osho of the left man.
Okay. Oh. That's I have it to be a little bit more proximal here.
30, né?
Rodolfo. Yes. I did the IVUS measurement here. It was about up to 28, 29 millimeters. If you go after to the septal branch here. So we are choosing now what will be a 30 millimeters stent. Okay. So Rodolfo is now positioned the guide
This-
wire distally to the LAD. Oh, a little bit. Okay. It's a
Okay.
little bit.
It's okay.
Yes, diffuse disease here on the left
Pull
main.
back the
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 balloon
balloons.
here. Okay. So perfect.
back the left circle.
Yes, we're
Guide wire?
removing. Yes, removing the guide wire so the being stuck after we use the stent on the left main towards to the LAD, and we're just removing the balloon here. So now we are moving the non-compliant balloon from the LAD to the left main here, and we are now asking, we're choosing the stent. It will be
3,5.
3.5 by 28 by
30.
30. Okay, that's just me check it out.
30,
3,5 by 30. 3,5 30. Stente, 3,5 30. Três e meio. 29. 29.
3,5.
29.
Okay.
So we'll be using now a
29.
29, 3.5, 39. It will be the also microport, but it will be the previous device. It will be not Liberty, so we are just
Soro.
opening it. And Rodolph, after this, what will be the next step? We're at
Pot.
pot. Okay.
Deploy the stent and then
We do proximal optimization
cross
and we
motivation
cross the guide
with
wire.
a 4-row balloon.
Okay, perfect. If it
And
something
cross-
happens to the diagonal, what be
I think it's
low
it's
probability?
be
Okay.
because there is no lesion in his ocean.
Okay. But we
It's
can
what-
just
it's your-
try to use if had pinched ocean, we had just used a balloon here,
Yeah.
correct? Okay.
Yeah,
so
it's going to be a provisional
Yeah.
technique to the
To the-
diagonal
yeah.
and two stent technique on the left main on the bifurcation.
LAD,
perfect. LAD to the circle
Circle.
LAD. Okay.
2 technique stents,
Yes.
none crush.
Yeah, up here.
We always try to use only one
Okay.
stent, right?
Stick.
Well, what's your opinion, Louis?
Yep. We also we try to use just one. It will be.
Yes.
But when you have to, and by I think by Angel we did, but the IVUS only showed that what we saw on the IVUS, né? That will be a suitable case for two stand
stents.
because there's a lot of classified.
It's easy to
Yes, to navigate and to cross
in
the
LAD.
the lesion here. We did a good preparation on the lesion here. Okay. So now we'll be checking out on two positions. We have to do the distal.
Just the
Yes, the distal
first the
LAD.
distal edge, the distal zone.
Yes.
Teste.
We have the several to make sure here. Okay. Just make sure. Okay. Just test here.
Okay.
Okay.
It's okay. Perfect.
Perfect. And I have to
By Angel.
By Angel.
And
Okay.
now
We are
the
using another
option,
projection to just
see
the
the option
option
of
for the LAD.
the option of the left man.
Yes, the left main. Sorry. Okay.
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 1 millimeter. Pull back. Teste.
Just testing here. Okay.
Wait.
Just releasing the
Wait.
stent here. 8 atmospheres here.
Deflate.
Just by 8 atmosphere, we don't use too much. You don't use a lot of time because it's a
To
left
avoid
main. Yes, to avoid.
distal dissection.
Yes, distal dissection and it's left main. You don't want to have hemodynamic surprise here when you deploying stent on the left main.
How long do you keep the balloon inflated on the left main?
10 seconds at the
Yeah.
most because I don't want we don't want ischemia here.
Okay.
Any surprise. So now Rodolfo is just pulling back a little bit. That's why you have to
10.
know. Yeah. Okay. 10.
Okay. 12.
Oops.
It's okay.
Okay. And how much importance you have to cover the Austin because you are now
Pulling back the balloon, right?
pulling back the balloon,
Okay.
so you have to cover the Austin. So okay, perhaps a test to know how.
Testinho para ver se
Yeah, we're gonna check.
We're gonna check it up. Okay, 1, 2.
Testinho nosso.
Just doing some tests here to check the results.
Outro teste.
Oh,
Ok.
okay. Perfect.
Testinho. Outro.
Oh,
Vai. Ok. Salvou?
sorry. Okay. So now we are moving back the balloon. We are doing now, as Rodolfo said, we're going to do pot here.
What Rodolfo did
Posso
right
ser-
now, Rodolfo
Posso
saved
dilate
the
the LID, please?
Yes.
The
Rodolfo
three
saved the
balloon.
fluoroscopy so that we don't keep recording all the time, cine.
Yes.
So it lowers our radiation dose at
Oh,
the end of the day,
yes.
right?
Yes, a very good tip here that Jose is, so you don't have to how can I say record everything. You can just do on fluoroscopy and then you save a lot of radiation.
That's
To us,
something
actually-
we don't see every day, right?
Yeah.
People taking care of radiation, especially fellows that
Yeah.
but at the end of the
Balão
day,
3
this
zero.
is a radiation
Diego, balão
you're
3 zero.
taking for your whole life, right?
Okay. So now we are not. Rodolfo said we are going to.
Posso
make-
dilate the LID first?
Yeah,
and
first.
Then pot.
Yeah, then pot. So we're going to use the same balloon here, the 320, 3 by 0 by 20.
Pega 4.8 pro tronco.
Yes, já tá lá.
4.8 pro tronco.
Here. Okay. Okay, perfect. So I'm now moving the balloon 3 by 8, 3 0 by 20 here on the left
Right.
main
Reach.
towards the LED here. Okay. Perfect. Okay, just a little bit more distal.
keep in mind that this is an
Which-
used balloon, right?
Yeah.
So,
and the angulation and the calcification.
yeah, that's why the
difficult
balloon is having some
the
difficulty
progress.
to go up to the proximal LAD. But
Vai.
as you can appreciate, the balloon is now on the
25.
distal part of the stand.
Okay.
25.
25 atmosphere here. We are making optimization from the LAD distal, the mid to the proximal portion
Dash.
now, and we are going to do some. Yes.
Okay.
Okay. No
Perfect.
dissection. Perfect. Okay. So now we
Now
are moving
pot.
to pot. Here we're going to use a 4 by 8 balloons. Is that correct, Rodolfo?
Yeah.
From IVUS was like almost a 4.5
It is
by.
important to do the POT correctly, so everything goes easily after that, right, Louis?
Yeah.
Uh,
The recrossing from
the
the guide wire.
recrossing is better. You don't go under struts.
Yes.
It has to be well done, right?
Yes.
So that's why Rodolfo chose a 4.0 by 8.
First thing, cross the to the left
Yes.
surface before.
Yes. Okay. Now it's the 4.0 balloon here. Just okay. I'm kind of anxious to see the IVUS image, the control. Wouldn't you, Jose? It's because it's I think it's pretty satisfied with the how can I say the angel here.
Yeah, it's very good result.
Okay, so now just a little bit, so you don't. Okay,
Okay.
perfect. You have to do pot. You have to touch a little bit from the ostium of the
Okay.
circ.
Little bit.
Yeah.
Distal.
Okay.
Right.
And we're
Okay.
up to the 24
Last.
atmosphere here. Okay, thank you. So
Right.
you're at the ostium of the lady here.
Okay.
In the guide wire here. Okay.
Dash.
Okay, let me do some tests here. You want to?
Espera. Right.
Whoop.
Okay.
Perfect. Okay.
Very good angiographic result, right?
Yes, yes.
Now
Now we are going to
The-
recross. You are going to recross on this projection here, Rodolfo? Yes, or the spider? You think it would be better?
first this in this
Yes.
because the save radiation.
Yes. Radiation is a little bit lower here. You have to make sure you try to do as distal as possible, but now you are recrossing after the decay crush here. So, okay, perfect. You're doing just a little bit of tip here.
This is the same guide wire.
Yes, that we use previous on
It's a
the
pilot 50.
pilot 50 on the circ that you used previous before. Okay, so yes, a little bit. Okay. So Rodolfo is now trying to recross the guide wire here. Okay.
Pede pra você dar um pouco mais.
That's why it's so important to make the how can I say the perfect decay crush. So you
position,
yes the position so you don't have trouble on recrossing and reaccess the side branch here. Okay. So now Rolf is trying to make some. Okay.
The mid portion of the.
Yes.
Okay.
Smoothly here. Yes. Perfect, Rodolfo. Not even take 10 seconds to recross. Okay. Remember that's calcified. You have two struts from stent and it's calcified. So after we recross, we're using a what balloon here? Will be a smaller or will be like a trio again here? Or what will you feeling? What will you feeling when you cross with the guide wire here?
If the a 3.5 cross,
Okay,
a 3.0,
trio new,
3.0, it's
new.
A new balloon, or
New balloon.
you want to use
we
the?
have only one.
Yes, we did.
Yeah.
You still now just use only one. Now the 4.0 after the
The
pot
second
here.
balloon, please.
Yes,
3.0
okay.
de pré, 3.012 de pré.
3012.
It's a new balloon. 3.0 by 12 here. If you don't cross, you have to go a little bit smaller
Downgrade,
here.
yeah.
Yeah, downgrade the balloon. It's an important tip for the newest interventionists because you don't have to worry. You have to downgrade the balloon here.
And people must have in mind too that we are on a public institution, and
Yes.
everything counts, right? Every
Yeah.
balloon, every stent that we use. So to treat
Every
more
drip
patients
from
and better treat patients, we must save on guide wires or the balloons.
dye here.
Dye
because,
too.
Yes, uh, we have to be concerned. That's what Fausto also always make us on our mind. But you have it's a public and you have to money isn't free here. So, but we do so much from the patients that are so proud from our institution here. So it's a 2.5 balloon by 12.
It's a
No,
3.0.
it's a
Trio,
trio.
trio. Okay,
Yes.
perfect. Yes, trio.
It's,
Okay,
wait a minute. Cranial view.
cranial view here.
The guide wire, LED guide wire, pull back a little bit. I will
Okay, just reposition the
position.
guide wire from the LED here. Okay.
Qual é? This
Yeah.
one.
Okay. But we can oh, here.
Okay.
Okay. Well, you can see the circuit here.
Yeah, the balloon.
Okay, so it is
LED.
the moving the 4.0 balloon here. Okay, perfect. And now we're
Bem pouquinho, tá?
just
Não.
a little bit the circ here balloon. So cover the Austin here. Okay, perfect. Now we are preparing for the kissing. So I just make up
Pode
to
ir. Ok.
20 atmosphere from the Austin from the circ.
Zé, só 3. Isso é 4. 3. Ou a gente troca, né?
Okay, so it's up to
So I'm at
Vai.
four
four
atmospheres.
atmosphere. Okay, so 4
Oito.
atmosphere. Wait, 8
Dez.
atmosphere. Okay,
Inflate.
1, 2,
3.
okay. It's important to deflate at the same
At the
time
same
because
time,
you
yes.
you can some now do some carina if you don't. Okay, disinf.
Teste. Tá
Okay,
duro, hein?
just 1, 2. It's a little bit hard to. Okay.
Remove the
Yes,
balloons.
remove the balloons. It's hard to make the injection with 2 balloons inside the catheter. Here. Okay. Oops. Here. Okay, so removing the balloon. You have at least 10 minutes to do the IVUS. Okay, Rodolfo. So we are
Okay.
okay. So removing the balloon here. Okay.
Some twist here.
Yes, some this here. Okay. Perhaps it's just remove both balloons here. Be a little bit better. Okay. So the IVUS.
IVUS, please. Cateter de ultrassom.
The IVUS here. Want to do it first? Circ or LED?
LED.
Here? LED?
This one.
Yeah. Okay. So now moving to the LED here. Okay, perfect. So Jose will be on. I was. Yep. Okay, so
Flash? Não. Flash.
Sardine doing okay. Uh, okay. We can
Okay.
do the MFR on the circ also, just to check it out that moderate lesion on the mid portion from the circ.
Ultrassom.
But
Imagem.
okay, so image from IVUS here. Okay, so it'll be okay. Thank you. You're just showing. So we're going to do the pullback. Can we do it?
Yeah.
Okay, doing the pullback here. So it's the same LED from the mid portion. There's some not some calcified here at 3 o'clock. 12 to 3 o'clock here. Okay, some. Okay, so there is no
The land zone.
disease here.
Distal land zone. Okay.
Okay, so hold
Very
Perfect.
good.
perfect distal transition here. It's well posed stand here. It's,
Well opposed. Well expanded.
yes, here a little bit. Okay, so there's it's the where is the start the calcified lesion here, but yeah, it's well posed here.
Yeah, but the balloon was enough to open the calcified lesion, right?
Yes, I think the okay side
And the
branch
area
here
is
and
okay.
the here it's at 3 o'clock.
diagonal
The side
branch.
branch, yes, the diagonal, the big huge diagonal will be the position. Now we're seeing the yes, the
Yeah.
okay.
Very
Good.
We're
good.
going to see the yes. We did the circ here. We're now on the left main, well opposed. Well, it's so well done here.
I'm pull back the catheter a little bit.
Yes, okay, well opposed. So it's okay.
Okay. Okay. It's
Okay,
the
so
order.
we're moving now to the circ here. That's perfect. So now we are making an IVUS control imager on the circ,
Yeah.
but the IVUS from the left main to the LED was okay. It was really good results here. Well posed, well expanded extent here. Uh,
Tava com soro aqui, a linha. Soro.
just reviewing here. Okay.
Deixa eu ver a foto da caudal. Acho que o guia saiu. Ok. Okay.
Okay, Rodolfo. Did IVUS went
Yeah.
across well here?
The wire is in the marginal branch.
Okay.
Okay.
So just position the guide wire here. Okay. And now you're positioning the catheter from the IVUS here.
Okay.
Okay, so we are going to do live
The
image
catheter
here.
is distally
Okay,
distant.
yes, this we are
Image.
going to do the pullback here. Okay,
Okay.
So pull back from the circ here, mid portion from the circ. Yes, some calcified lesion here, not so much here. Okay. Some marginal branch here.
A little
It's almost,
branch
yes,
and
almost
the
like
stent-
9 degrees
the
of
stent
calcium
coming.
here. That beautiful transition here. You can see the stent here, well opposed, well expanded here. It's good results here. We are just moving back to
108
the proximal.
degrees of calcium.
Yep. Some calcium at 11,
But
almost to
the
12.
expansions,
Yes.
it's okay.
Okay. Perhaps a little bit here about the expansion here. We're going to the. Okay. That's perfect. Full coverage from the Austin here, Rodolfo.
Yeah.
And
Yeah.
we're up to the left main.
Okay.
Okay. Perfect. Perfect. Okay. That's
It's okay.
okay. You did already made an IVUS from the elephant. Oh, perfect. So, can I show the MFR from the circ here? Because
Yes.
I think if you can move the screen to the MFR here, the physiology here, you're going to just do some tests here. Okay, so I think was this one here. Okay, so we're doing this on live. So just to make sure, okay, this was this. Okay,
We have a few minutes. Okay.
yes,
We have
okay.
5 minutes left, so we're gonna do the final angel, and Louis is also gonna
Nitro?
make the physiology assessment from the distal LAD and also the circumflex. But I hope you guys enjoyed it as we did. It was a beautiful case to do, perfectly executed by the team, and especially Dr. Rodolfo.
Yeah.
Do you want to add something, Louis?
No, just making just confirm here the. Remember you are doing the angel here. Did you remove the guide wires? Okay, just okay. Perfect. We are doing okay.
Okay.
I like what I see. Do you like it? I think it's very good. We have the ostium
Tirar.
cover from the
Remove the
IVUS
device.
assessment.
So they just did a 0.99 for the MIRFAR on the circ. Let's move to the big screen. The see the final control angel here. If
Spider.
you can show, appreciate here. Okay, so let me see here. Jose, the angel.
Contraste.
Vamos lá.
Contraste, por favor.
So spider view here. Okay,
Yeah.
it's good.
Okay.
Really, really good. Okay. So just it's the spider view. What do you think?
Very good result,
Very
right?
good results here. Really, really good results here.
And what about the
Yeah,
physiology?
physiology, it was normal on the mid portion from the circ.
Cranial view.
Cranial view,
The
just
best one.
check the LAD here. But the transition stand was by the IVUS was perfect. Okay,
Okay.
okay,
Good.
perfect. That's good. Some moderate lesions here, disease on the mid portion
About
here.
50, 40,
50%.
50%.
50% here.
Yes,
Okay.
and the diagonal branch is also open. Has TME3 flow.
No lesion.
The ocean is free.
The baseline
Right?
angle.
Yes.
It's really, really beautiful. Okay.
So we have a beautiful
I'm
result.
okay.
Can we see? Can we take a look at the MIFR results here? Can I have it on the big screen?
Yes, it's okay. Perfect. So let me check the last key here. Confirm the AD. Just make a control MIFAR from this. Okay.
As you can see, the NGO Plus and MIFR is very straightforward. It automatically identifies the vessel and it calculates also automatically just with one projection.
Yes, perfect. 0.88. It was. I can if you can show the first one. It will be really fast. Here, okay. Just make sure I can make the pre.
It's a normal value because
Yes.
it was validated with
With
FFR.
FFR.
So we have a cutoff of 0.8.
This is the previous lesion here. Just making correction here. Okay.
Yeah, but the lesion is not well appreciated on this
view.
projection because there's the septal branch that is covering the most severe lesion right there.
But the yes, 0.70. Yes, was how can I say? It was positive
Okay.
from MIFAR and was in the
So we have negative physiology on both left circumflex
yes.
and the LAD. We're gonna treat the right coronary on a second moment because we use about 100 mLs of contrast. So we're gonna leave it to another day. But it was a pleasure to be presenting this case with my colleagues Louis, Rodolfo, and Diego. I hope to see you guys again soon. Thank you.
See you.
Thank you.
Thank you.